Hello, everyone, and welcome to our module on ventilation and perfusion. Let's start by talking about lung perfusion, which refers to the flow of blood through lung tissue. And the first thing you need to know about lung perfusion is that when a person is sitting in an upright position, so either standing or seated upright, the blood flow distribution to the portions of the lung is uneven. In other words, not every section of the lung gets the same amount of blood flow. This is because of gravity. So at the apex, which is the top of the lungs right here that I'm circling with my pen, that's where there's the lowest blood flow. And that's because gravity prevents blood flow from being maximal in these sections of the lung. And at the base, which are these sections down here, that's where the lung tissue receives the highest blood flow. And so because of this variability in lung perfusion, we divide the lung into three different zones to describe how the tissue is perfused with blood. So here's a drawing of the three zones of the lung in terms of lung perfusion. So zone 1 is at the apex. This is the area that gets the lowest blood flow. Zone 2 is in the middle, and then zone 3 is the base. That's the portion of the lung that gets the highest amount of blood flow. It turns out that just like perfusion, the ventilation of the lung also varies by lung zone. Lung ventilation refers to the amount of air that comes in and out of the lungs with each respiratory cycle. And just like perfusion, ventilation is highest in zone 3 and lowest in zone 1. So if we look at this drawing on the screen, once again, the apex, that's where zone 1 is. That's the lowest ventilation. Zone 2 is in the middle, and zone 3 down at the bottom, the base has the highest ventilation. Just like perfusion, this is also caused by gravity. The reason ventilation varies by zone is that the upper lung is pulled down by gravity and it compresses the lower lung tissue and pushes more air out with each respiratory cycle. This leaves more room for filling the base with the next breath, and so as a result, you get these variabilities in ventilation based on the zones of the lung. However, you should know that the ventilation variation is smaller than that of blood flow. So in other words, even though blood flow is lowest at the top of the lungs and so is ventilation, the change from bottom to top is smaller for ventilation compared to perfusion. So now that we understand that, we can talk about a very important concept in pulmonary physiology, and that is the ventilation-perfusion ratio, also called the VQ ratio. And it gets this name VQ ratio because V stands for alveolar ventilation and Q stands for pulmonary blood flow. And in the lung, you want ventilation and perfusion matched for ideal gas exchange. If you have too low of a V relative to Q, in other words, an underventilated area of the lung, or if your Q is too low relative to the V, you have an underperfused area of the lung, this is inefficient for gas exchange. And the normal VQ ratio for the lungs as a whole is a little bit less than 1, about 0.8. This is what yields the normal PaO2 and PaCO2 we expect to see on a blood gas from a healthy patient. That's a PaO2 of about 100 and a PaCO2 of about 40. And this is all shown in this little cartoon here on the slide. But if you have a normal VQ ratio and matching of ventilation and perfusion, you get those normal results for oxygen and carbon dioxide content of arterial blood. VQ mismatch refers to the situation when you have a mismatch between ventilation and pulmonary blood flow. So for example, if your VQ ratio got very high, that represents a mismatch between V and Q. And basically a high VQ means you have too much ventilation for the amount of blood flow that you've got. And this means you're wasting ventilation. So this is wasted effort by the body. You're overventilating the lungs more than you need to. What's a bigger problem, however, is a low VQ. This means you have underventilated sections of the lung where there's lots of blood flow but not enough ventilation. In other words, you're wasting perfusion. And this is bad because a low VQ will cause hypoxemia. Basically, you have more blood flowing through a section of the lung than you do ventilation, so you don't fully oxygenate the blood. As a result, you can get a low PaO2 and a low hemoglobin percent saturation. And as I talk about in the videos on hypoxemia and hypoxia, this is the most common cause of hypoxemia. Basically, what a low VQ ratio means is the ventilation is insufficient to fully oxygenate the blood. Now, when this happens, there is a physiologic response from the body. The pulmonary vasculature will vasoconstrict in response to hypoxia. The idea here is for blood vessels to constrict in underventilated portions of the lung, and forcing blood to well-ventilated regions is what the lung wants to do. But despite this being present, there can still be blood flow through poorly ventilated portions of the lung to some degree, and that can lead to a low VQ ratio, which is an example of VQ mismatch causing hypoxemia. Let me pause here and mention some terminology around VQ mismatch, because this is often confusing for medical students. So in pulmonary physiology, when we say there's a VQ mismatch, we usually mean there's a low V relative to Q, meaning a low VQ ratio. And we talk about this as a VQ mismatch mostly as a theoretical concept because it causes hypoxemia. In nuclear radiology, however, a VQ mismatch is a positive finding on a VQ scan. A VQ scan is a test used to diagnose pulmonary embolism. The patient inhales a radiolabeled gas and a radiolabeled tracer is injected into the veins, and you look at the ventilation and perfusion and compare them to one another to make sure they're equal. So for example, on the screen here is a ventilation perfusion scan. On the left side are the lungs lighting up when the patient inhales the radiolabeled gas, and you can see both lungs fill up entirely with this radiolabeled gas. On the right is the perfusion after a radiolabeled tracer is injected, and if you can appreciate, there's a portion of the top of the right lung here that is not being perfused, and that's the finding you get when there's a pulmonary embolism. So a VQ mismatch in nuclear radiology means you have a portion of the lung ventilated but not perfused. It's used as a diagnosis of pulmonary embolism. And so even though both of these things are proper uses of the term VQ mismatch, they're used in totally different scenarios and they really mean different things. In pulmonary physiology, a VQ mismatch is a theoretical concept about the causes of hypoxemia. In nuclear radiology, it's a positive finding on a test for pulmonary embolism. So now let's return to the concept of the ventilation to perfusion ratio. And we talked earlier about how both ventilation and perfusion change when you go from zone 3 down at the base to zone 1 up at the apex. Well, it turns out that the ventilation to perfusion ratio also changes as you go from the base of the lung to the apex. So in zone 3, down at the base of the lung, you have the most blood flow. You also have the highest ventilation, but the increase in blood flow is much greater than the increase in ventilation that you get down at the base. So it turns out the VQ ratio is actually lowest at the base. What this means is that you have a low VQ ratio, you have relatively underventilated lung tissue at the base, and you're wasting blood flow at the base because there's not enough ventilation to match it. In zone 1, up at the apex, you have the lowest blood flow and the lowest ventilation, but the highest VQ, and that's because the decrease in blood flow is much greater than the decrease in ventilation that you see in going from the base all the way up to the apex. So at the apex of the lung, what you have is wasted ventilation. Basically, you're overventilating the lung tissue more than you need to in order to oxygenate this blood, and that's an inefficient form of ventilation. So the take-home points here are that V and Q both decrease as you go from bottom to top, in other words, base to apex, but blood flow decreases more, and this causes the VQ ratio to change such that it's lowest down at the bottom and highest up at the top. So on this slide, I've summarized all the points you want to remember about how ventilation, perfusion, and the VQ ratio change in going from zone 3 at the base of the lungs to zone 1 at the apex of the lungs. So remember that the average VQ ratio for the entire lung is 0.8. Even though it's not equal in all zones, it's on average 0.8. And this produces normal findings on an arterial blood gas of a PaO2 of 100 and a PaCO2 of 40. Well, up in zone 1 at the apex of the lungs, you have a reduction in ventilation, but a greater reduction in blood flow Q such that the VQ ratio is high. It can be as high as 3.0. This is going to produce blood coming out of zone 1 that's oxygenated to a greater degree than normal because the VQ ratio is so high. And the PaCO2 is going to be lower than normal, once again, because you're excessively ventilating the blood that flows through here so you can remove more carbon dioxide than you would on average. Down in zone 3 at the base, we have the opposite situation. So V is higher down here, but Q is higher to an even greater degree. This produces a low VQ ratio. It can get as low as 0.6. And this is going to under-oxygenate the blood. So the blood coming from zone 3 is going to have a PaO2 of around 90, which is lower than normal. Also, the PaCO2 can be 42, which is higher than normal. And these things are happening because the VQ ratio is low and you're underventilating the lung tissue relative to perfusion. And if you know everything I've put on this slide and you understand it, you can answer lots of pulmonary physiology questions about the different features of the different lung zones. Let me make one additional point about zone 1. So as we said before, zone 1, which is the apex, has the lowest blood flow but the highest VQ ratio. This means that the tissue in that area has the highest PaO2 and the lowest PaCO2. This is what we just saw on the last slide. So in the infectious disease section, I talk about tuberculosis, which is a mycobacterial infection of the lungs. And tuberculosis likes to infect the upper lobes of the lung, the apices, zone 1. And the reason for that is because at the apex, you have the lowest blood flow, so it's hard to get white blood cells into the lung to fight the tuberculosis infection. And you also have the highest ventilation, and tuberculosis grows well in oxygen-rich environments. So zone 1 of the lungs is the ideal environment for tuberculosis infection. And if you look at this x-ray on the screen here, this is a cavitary lesion of tuberculosis, and that's in the upper lobe of the left lung. And once again, this is all because of the VQ ratio in that portion of the lungs. Now let's talk in a little bit more detail about pulmonary blood flow. And specifically, we're going to talk about blood flow through pulmonary capillaries. Remember, blood flow through pulmonary capillaries is what allows the blood to pick up oxygen and release carbon dioxide. So normally when you have a capillary, you have an arterial pressure upstream of the capillary and a venous pressure downstream. And let's say the arterial pressure was 100 and the venous pressure was 20. This difference between the arterial and venous pressure is what drives blood flow. We call that the AV pressure difference. But in the lungs, there's an extra variable that's not present in systemic capillaries, and that's the alveolar pressure. The alveoli are outside the pulmonary capillaries, exerting pressure down on the capillaries. And if this alveolar pressure were very high, it could actually compress the capillaries and there could be no blood flow, and that would convert sections of the lung into dead space. So when we're talking about blood flow through a pulmonary capillary, in other words, from the pulmonary artery over to the pulmonary veins, going from deoxygenated blood on the right side of the heart to oxygenated blood on the left side of the heart, we have to not only account for the pressures in the pulmonary artery and the pulmonary veins, but we also have to account for the pressure inside the alveoli. And so just like we saw earlier when we were talking about ventilation and perfusion and VQ ratios, pulmonary blood flow through the pulmonary capillaries also varies by zones of the lung. So to understand this, you first have to appreciate the basic principles here. So the pressure of the gas inside the alveoli, the P sub big A, is relatively constant throughout the 3 lung zones. But at the base, where you have the most blood flow, you generate a lot of arterial pressure and therefore a lot of venous pressure. So PA and P sub V are highest at the base. And then at the apex, the situation is reversed. Because of gravity, there's relatively little blood flow at the apex, so P sub A and P sub V tend to get lower. So if we look at zone 3 down at the base here, we have the situation with the highest blood flow. We talked about this before. And at the base of the lungs, the pressure in the arteries and the veins are both higher than the pressure in the alveoli. This is a good thing. It means the pulmonary capillaries are not going to be compressed. In zone 2, the alveolar pressure is in between the pressure in the pulmonary arteries and the pulmonary veins. And then finally, in zone 1 up here at the apex, we have a situation where the alveolar pressure can get higher than the arterial pressure and potentially compress the pulmonary capillaries. And this contributes to the minimal amount of flow that you get at the apex. We've already talked about this. It has the lowest blood flow because of gravity and also because of this phenomena where the alveolar pressure can get higher than the pressure in the capillaries and can smush the capillaries, cutting off blood flow. So just to make this very clear, let's go through the lung zones one at a time. So zone 1 is the lung apex, and this is the area of the lung where pressure in the alveoli can become higher than the pressure in the arterioles feeding the pulmonary capillaries, and therefore also higher than the pressure in the veins draining the pulmonary capillaries. And this could compress the capillaries and cut off blood flow. Now, normally in healthy individuals, P sub A, in other words, the arteriolar pressure, is just high enough to keep the capillaries open and drive blood flow. Therefore, zone 1 is perfused with blood, but at a low flow rate. And we already talked about how the flow rate, the perfusion, is lowest up here at the top. If, however, there's a pathologic state that changes P sub A or P sub big A, this can lead to capillary compression. So for example, in a person who's in hemorrhage or who has shock, P sub A, the arterial pressure, can go down. And when this happens, the alveolar pressure of gas can become higher than P sub A, and this will compress the capillaries, and you will stop having blood flow to the apices of the lung. This will create dead space. Another possibility is if the patient is intubated and placed on positive pressure mechanical ventilation. In this situation, P sub big A goes way up. That's the way mechanical ventilation works. It creates a very high pressure inside the lungs, and this also can cause capillary compression up at the top of the lungs at zone 1. When this happens, zone 1 becomes dead space. It will be ventilated, but it won't have perfusion because the capillaries are shut down. Zone 2 is the middle zone of the lung, and this is the zone where the pressure in the arterioles is greater than the pressure in the alveoli, but alveolar pressure is greater than venous pressure. What this means is that you will have blood flow, you won't have compression of vessels, but what drives the blood flow is the P little a, P big A difference, not PA, PV like in systemic vessels. So remember, we talked before about how if you had a capillary, the pressure upstream in the arterial side compared to the venous pressure on the downside, this is what drives blood flow. That's not what's happening in zone 2. What's happening is the pressure out here in the alveolus, the difference between these two pressures is what's driving blood flow, and that's because this P sub big A is greater than V, and therefore it determines whether there is blood flow and how much blood flow there is. And then having said all that, zone 2 is where ventilation is best matched to perfusion. This is where you have a VQ ratio very close to 0.8, the average for the lungs as a whole. And then finally, zone 3 represents the base of the lungs, and this is the portion of the lungs where all the vascular pressures are greater than the alveolar pressure. So the pressure in the arterioles feeding the pulmonary capillaries is greater than the pressure in the veins draining the pulmonary capillaries, and both of these pressures are greater than the pressure of gas in the alveoli. This means that in zone 3, we have blood flow driven by the AV pressure difference, just like in systemic vessels. Basically, there's no opportunity for the alveolar pressure to compress the pulmonary capillaries here. And then as we talked about earlier, in zone 3, the VQ ratio is the lowest, but despite that, zone 3 affects gas exchange the most, and that's because of what we've already talked about. You get the most blood flow through zone 3, so this is where the most gas exchange occurs, despite the fact that it has a low VQ ratio. Zone 3 is really the workhorse of the lungs. It does a lot of the work of oxygenating our blood because it receives the most blood flow. So one of the reasons that pulmonary physiology can be so hard to learn is because there are a lot of ways that they can show you the concepts graphically, and this can be confusing for students. So let me just show you a couple of classic pulmonary physiology graphs related to the lung zones so you've seen them at least once. So in this graph, we've got the PaO2 along the bottom and the PaCO2 along the y-axis. So mixed venous blood coming into the lungs is right about here, okay? It has a PaO2 usually around 40 or 50, and a PaCO2 of 45 or so. The air that we inspire has a PaO2 of 150, and it has essentially no CO2. And then in the middle of this graph, we have the 3 lung zones, and we talked about this earlier. So zone 2 is where you get blood that's closest to a normal arterial blood gas. You get blood that has a PaO2 of 100 and a PCO2 of 40. In zone 3, at the base, you have a low VQ ratio, so you don't quite oxygenate the blood as well as you do in zone 2, and the PaCO2 can still be a little high. And then zone 1 is where you have that high VQ ratio up at the top of the lungs, so you actually over-oxygenate the blood and you remove lots of carbon dioxide. So just make sure you understand this graph. It's nothing different from what we've been talking about in this video. It's just displayed graphically. And then here's another pulmonary physiology graph that you could be shown on an exam. It shows the VQ ratio, blood flow, and ventilation as you move from the apex to the base. And so the red and the green lines here, which are blood flow and ventilation, you can see they both go up as you go from apex to base, but blood flow goes up more, and that's what we talked about earlier. And then because blood flow changes more, the VQ ratio goes down as you go from apex to base. Once again, nothing new here, the same concepts we've already talked about, just being shown to you graphically. In the video on hypoxemia, I talk in detail about shunts, and I'll just briefly mention them here because to ventilation and perfusion. So a shunt is an extreme version of a VQ mismatch where there's no ventilation relative to perfusion and the VQ ratio becomes 0. This means that you have blood flow, you have Q, you have perfusion without ventilation, so blood's going to go from the right side of the heart to the left side of the heart without gas exchange. Now, this happens to all of us, even people with healthy lungs, to a very small degree. There's normally a small shunt fraction of about 2 to 3% of our cardiac output. This represents blood flow that goes from the right heart to the left heart without flowing past alveoli, but it's a very tiny amount of our cardiac output. In certain disease states, the amount of shunting can go up, and that can lead to hypoxemia, and it's a special kind of hypoxemia where when you administer oxygen therapy, the oxygen level does not rise. To understand this, let's look at the cartoon I've shown on the slide here. So we've got venous blood coming into the lungs. So venous blood has a PaO2 of 40 and a PCO2 of about 46. Over here, some of the blood is going to go through normal lung tissue with a normal VQ. That blood is going to become fully oxygenated, so the PaO2 will rise to 100, and that blood is going to offload its carbon dioxide so that the carbon dioxide level falls to 40. So this is all fine, but then over here, we've got some areas of the lung where there's shunting going on and the VQ is 0. Because the VQ is 0, there's going to be no change in these characteristics of venous blood. It's just going to flow to the other side of the lungs without ever changing the amount of oxygen and carbon dioxide it holds. When it comes out, it's going to mix with the normal blood, and we're going to get something like we've described down here. So we're going to have an overall low PaO2 and an overall high PCO2 compared to what we would normally have, which is a PaO2 of about 100 and a PCO2 of about 40. So that's the first thing that happens when you have a shunt is you get hypoxemia. The other thing to know about is giving more oxygen won't help because the oxygen won't get over to this side where there's no ventilation. It will go to this side, but this side is already fully saturating the hemoglobin in the blood to 100. It can't add any more oxygen beyond that. So that's why in shunt, oxygen therapy does not help the patient. That's the hallmark of a shunt. And once again, I discussed this in much more detail in the video on hypoxemia. And then I'll finish this video by talking about how ventilation and perfusion change during exercise. So when you exercise, your muscles demand more oxygen. This is going to lead to your ventilation rate increasing. As you probably know, you breathe faster when you exercise. Also, when you exercise, your sympathetic nervous system becomes active and your cardiac output goes up. So both ventilation and perfusion of the lungs are going to increase with exercise. The VQ ratio, however, it turns out approaches 1 for the lungs overall. Normally, it's about 0.8, and it goes up slightly with exercise. That's because even though there's more blood flow and more ventilation, the increase in ventilation is greater than the increase in blood flow, such that the VQ ratio goes up. You also see a more even distribution of the VQ ratio in the zones of the lung with exercise. It doesn't vary as much in going from the base to the apex. It's also important to understand, however, that with exercise, there should not be a change in the oxygen content of arterial blood, the PaO2, and the carbon dioxide content. This can be a tricky concept to get your mind around. So shown here is what you normally see in an arterial blood gas, a PaO2 of 100 and a PCO2 of 40. And this is the same thing you should see in a person with exercising. Blood is flowing through pulmonary capillaries like I've shown here. It's exchanging oxygen and carbon dioxide, and it's generating the normal blood gas findings in the arterial blood. In order to do this, however, the lungs have to work harder. So normally, when you're not exercising, this is what venous blood looks like. PVO2, the amount of oxygen in the venous blood, is about 40, and the PVCO2 is about 46. Well, this stuff can all change with exercise. So the PVO2 instead of 40 might go down to, let's say, 30 because you're exercising and you're pulling more oxygen out of the blood. The PVCO2, which is normally 46, could go up to, say, for example, 50 or something like that, because you're producing more CO2 from the exercise. So even though the oxygen and carbon dioxide content of venous blood is going to change, if your lungs are doing their job and they're healthy and you're increasing your ventilatory rate and your blood flow, you should still get normal findings out in the arterial blood. So this is an important thing to understand. In board exams, they may describe a person who is exercising. The venous carbon dioxide and oxygen content may change, but if it's a healthy person with normal lung function, you shouldn't see any hypoxia or hypercarbia with exercise. The lungs are just going to do their job more efficiently with exercise to try and get that arterial blood back to the normal levels of oxygen and carbon dioxide. And that concludes our module on ventilation and perfusion.